So once again, good evening and a very warm welcome to our webinar on gynaecology treatments. My name is Vicky and I'm hosting this session. I'm delighted to be joined by our expert speakers, Mr. Abhishek Gupta, consultant urogynaecologist, and Miss Anna Zakaryan, consultant gynaecologist. Tonight's session will begin with a presentation from Mr. Gupta and Miss Zakaryan, followed by a live Q&A. If you've got any questions at any point, please do feel free to submit them using the Q&A icon at the bottom of your screen. You're welcome to ask anonymously or include your name, but just a quick note that the session is being recorded, so if you share your name, they may be visible in the recording. And to help us get through as many questions as possible, we please ask that you keep your questions brief. If you're interested in booking a consultation, we'll share all the relevant contact details at the end of the session. I'm now going to hand over to Mr. Gupta to start the presentation.
Thanks, Vicky. So just as terms of brief introduction, so my name is Abhishek Gupta. I'm a consultant gynecologist and my subspecialty interest is in urogynecology. So I did my training in, majority of training in Southeast and my teaching hospital were Guy's and St. Thomas's. Apart from urogynecology, which is related to prolapse and incontinence, I also do a fair amount of keyhole laparoscopic surgery. And also to that effect, I'm a member of Royal College of Urogynecologists as well as with Royal College of Obstetrics and Gynecology. And now I'm also a robotic surgeon. And do a fair amount of robotic surgery, and I'm also a member of British Irish Robotic Association of Gynaecology. So that's my brief introduction. We have in part done, in past done webinars on urogynecology, which has been very well attended, and a lot of questions have been asked, and the feedback when I've seen the patients in the clinic has been very positive. But that's a specialty on in itself, and it's a wider webinar to do. So we're trying today not to cover the urogynecology, which will come in due course of time in another webinar. So the prolapse and incontinence will be coming in the next webinar at some point. And today we are going to, apart from prolapse and incontinence, what are the common referrals we get, and we want to explain what this is all about, what common issues gynecologists do get referred to, and how they're managed, and what to expect and not to expect. So that's our aim, to empower you. And we will try to see if there is any common questions which we can try to answer at the end. So I just wanted a brief summary. So I'll now hand over to my colleague Anna to introduce herself.
Good evening, everyone. I'm Anna Zakaryan. I'm also a consultant gynecologist. I'm based on NHS in the Dartford Valley Hospital. I've been part of Benenden Hospital for a few years now. My interest areas are urogynae as well as ambulatory care, minimal access, HRT, and I'm generalist by the nature. So very happy to answer all your questions today. I won't make it last long. Let's proceed.
So apart from, as I said, from incontinence, prolapses, these are the 4 or 5 commonest referrals we get. So we get quite a few patients who get referred for us with endometriosis. Then we get quite a few patients who refer for fibroids, and then some HRT advices, which we have a specialist GP here who deals with a lot of HRT. So we get into the HRT limbs when there's a problem. And we obviously, heavy menstrual period is again a very common referral for us. And then ovarian cyst. So the pros and there's different type of ovarian cyst needing different time of treatment. And then last but not the least, polycystic ovaries, which get referred quite often. And there are quite a few myths about it, about polycystic ovaries, and what to expect and not expect. So our idea is to empower you to understand this, and also to see where you really need to help and what helps are available. So that's the common referrals we do get in our gynecology services here. So I'll start with endometriosis. So what is endometriosis? So if I may explain, this is what is called lining of the womb. That's here. So it's a two-dimensional picture. So this is a horizontal section where the womb is cut in half. So if you notice, this is the womb. This is the lining of the womb or the cavity. This is vagina. That's your tube, which takes an egg from the ovary, which goes into the womb. So that's your ovary. And that lining of the womb is called endometrium. So when you get an endometrium, and that endometrium sheds every month when you have a menstrual cycle. Now, this endometrium or spots of endometrium can be found anywhere in the pelvis. You can find it in the tube, you can find it in the pelvis somewhere, you can find in the bowel or the bladder or anywhere else in the pelvis. When it is found outside the womb, this is called endometriosis. Now, there are so many theories why endometriosis happen. Some is genetic theories, some is a retrograde menstruation. So rather than coming the blood through the vagina, comes to the tubes and endometriosis gets deposited. There are a lot of theories, but nobody has come to find out why the endometriosis happened. So what we know about endometriosis is a problem of reproductive age group. That's for sure, because it is hormonally driven. So endometriosis is not a problem of non-reproductive age group. So endometriosis can happen when 13 or 14 when you have a menarche to time you have menopause. That's what we know, that endometriosis is triggered with hormones. How it happens, nobody knows. Then what? And then a common question which is asked, and a lot of scan which that's get reported, and it says you got a bit of adenomyosis. This is again a common question get asked. And what is adenomyosis? Adenomyosis is slightly bulky uterus or bulky womb. And when the endometriosis tissues do get into the muscles of the womb, it's called adenomyosis. So it just appears slightly more bulky. And adenomyosis typically presents with heavy, painful period. The ultrasound scan or even MRI can only suspect adenomyosis. The only way to 100% confirm that you have adenomyosis or not is when if somebody has a hysterectomy and it goes to the lab and then biopsy is done. That's the only way to confirm that adenomyosis is there or not. Now, with endometriosis, and this is the commonest thing which we get referred is pelvic pain. And this pelvic pain is usually gets worse just before your period is going to start. And usually starts getting better as the period progresses. You can have pain during intercourse, depending on where the endometriosis is, because if you imagine this is a vagina here, in the front, because it's a horizontal section, longitudinal section, the front is the bladder, back is the bowel. So if you have the endometriosis behind the womb and between the bowel, you can have very painful sexual intercourse, which is usually quite deep. And you can also have pain opening your bowels or passing urine, depending on the location of endometriosis. Bleeding from bowel and bladder can happen, but usually very unusual until unless you have something called a very severe form of endometriosis, which is endometriosis which has now gone into the bladder and gone into the bowel. As a result of constant pain and sometimes heavy periods, you can feel quite exhausted and tired. Endometriosis can affect fertility, but it's usually when it starts, but it usually affects fertility when it's slightly more severe form of endometriosis. Treatment of endometriosis does improve your chances of fertility quickly once you have the treatment done. But it does affect your fertility towards the end, not very early. So when do you need to see a healthcare professional? So if you get painful, heavy periods, or other symptoms which I just described, and things like contraceptive pills or things like normal pain relief, or if you go to your GP, they sometimes give you a tranexamic and mefenamic acid. One tablet is to reduce the heaviness of the period, and the other tablet is the pain. If things are not getting optimally controlled, then you may like to get checked. It's not necessarily you have endometriosis, but you may like to get checked. So what do you do when you come to us? We obviously take history because we want to understand what's really affecting your quality of life here. Then we do an examination, and depending on your symptoms, we may do an internal examination. If it's affecting your, if you're having painful intercourse, we may examine you internally as well. And then the commonest investigation is ultrasound scan. So what ultrasound scan is very good in picking up if you got endometriotic cyst on your ovary. So that lining of the womb, if found in the ovaries, and it can form a cyst, it's called endometrioma, which is the cyst in ovary. The ultrasound scan is very good in picking up that you have endometrioma. Sometimes with the scan, your ovaries are not moving very well. And if they don't move very well, and they look like they're stuck somewhere, then also it can give you a signs of endometriosis. A couple of our sonographers have obviously done advanced courses in picking up the endometriosis via scan, but otherwise, the surface endometriosis, and if the endometriosis is involving your bowel, is very difficult to pick it on ultrasound scan. From an investigation point of view, MRI then becomes the gold standard way of knowing if you have severe endometriosis, i.e. if your bowel is involved, or your ureters is involved, or your bladder is involved. But even MRI can't pick up small spots of endometriosis, which is surface endometriosis. MRI can't pick it up. The only way that can be picked up is keyhole surgery of laparoscopy. Otherwise, small spot of endometriosis are not picked up on MRI. So what is our treatment strategy? So if patient comes to us with all the symptoms, depending on their personal situation, whether they're now early in the menstrual reproductive age group, they haven't had children, they still want more fertility, they come to us, we don't know whether they got endometriosis or not. If the scan is showing that you got an endometrioma, we know exactly that you got endometriosis. Majority of patients who gets referred, the scans are normal, but they have got the symptoms. So what is our aim for treating? So we get an MRI done. If you got severe symptoms, MRI comes normal. So now we know that you don't have a severe form of endometriosis. So the aim can be how to treat your symptoms. However, as I said, the only way to find out is if laparoscopy or keyhole surgery to find endometriosis. And because MRI has ruled out any severe form of endometriosis, I would recommend before we do any laparoscopy, which is obviously a general anesthetic procedure, comes with its pros and cons, we treat it with less invasive options. And I'll talk about less invasive options in a minute. And obviously, once MRI has ruled out severe endometriosis, and if we don't know and we put a laparoscopy in, we only find endometriosis in 50% of patients, approximately. So there is a big chance of it being a negative laparoscopy. So what is our strategy for treating endometriosis without being proven on a scan or MRI? Obviously, as we talked about the pain relief, then as I said in the beginning, that we know is endometriosis is a disease of reproductive age group. So we can give you a combined oral contraceptive pill or a Mirena coil, or even if you can have an implant or injection of DPO. What it does is it stops you ovulating. And when you don't ovulate, the anovulatory cycles are much less painful because that doesn't react the same way. And that helps your symptoms. And then if you have endometriosis on MRI, or you usually do pain and all that's not responding by basic oral contraceptive pills or implant or a coil, then we think about going down the route of laparoscopy, which is a keyhole surgery and the general anesthetic. And then we try to treat the endometriosis. There is some questions which were asked to us before we started the webinar. One is the excision and whether we offer excision. It really depends on where the endometriosis is. If you've got tiny spots of endometriosis, you can't keep excising them. You have to burn them. But if you've got a nodule, you can't burn them, or you shouldn't burn them. You should excise them. And where it is. We do try to offer endometriosis treatment here. Only treatment we don't do at Benenden is if you have a severe endometriosis. When I mean by severe endometriosis is if your bowel and your ureter, which is tube draining cochlear bladder, is involved and stuck. The only reason we don't offer this is because we're not endometriosis center, and it requires a joint operating with the colorectal surgeons, and we do not have that facility of joint operating here. Last but not the least, if you're completely a family, if you know endometriosis or you got symptoms, you've tried less invasive options, then we can look at more definitive treatment, which is a hysterectomy, i.e. removal of womb, neck of the womb. If you're closer to menopause, then we can, and you have endometriosis, we can consider taking your ovaries out, but that will give you menopause. But that becomes a complete treatment of endometriosis, and then less chances of endometriosis will come back on you. So that's in short, in next 10 minutes, what endometriosis is about and what our aims of treatment is. We have talked about this. So next common referral we get is fibroids, which is a benign muscle mass, lump on the womb. But I'll let Anna talk about the fibroids.
Yes, thank you. As it said already, fibroids are benign, and in vast majority of cases, they are non-cancerous growth of the muscle in the womb. They vary from size and the position. They can be really small. Ultrasound investigation these days picks up them when they are even a millimeters in a size, and they can grow really large, up to 15, even 20 centimeters, we've seen recently. Many women do have fibroids and they don't have any symptoms. So it's largely picked up due to one or the other reason when women get investigation with a scan or MRI. On the picture, as it shows, as you can see, the positioning of fibroids can vary. So when they are completely buried in the muscle of the womb, they are interstitial, intramural. These ones halfway through the cavity, but vast majority of this fibroid is still buried in a muscle. So these fibroids, we still treat them as intramural. But this fibroid is completely in the cavity, sticking out in more than 50%. So these fibroids, though they are usually smaller than the others, they are clinically more important because these will need to be excised to treat the symptoms. The fibroids that are grow outside of the muscle, they're called subserous. So this is some subserous and some intramural. So they all vary between with the sizes and the location of the fibroids. What they do cause heavy, prolonged menstrual bleeding. And in the long run, that can also affect women's well-being by causing anemia, fatigue, tiredness. And it doesn't matter how much iron you take, it's very difficult to replenish the iron reserve because women continuously losing it with the blood. It can cause abdominal pain and pressure depending how big are these fibroids. Most importantly, how they position. They can press on the vital organs and nerve plexuses in the pelvis. Because of the positioning, they can cause pain during intercourse. Obviously, if they are located in the front of the womb and they are pressing on the bladder, they can give you some bladder symptoms such as frequency, urgency, feeling constant pressure on the bladder and need to run to toilet. They can compress the bowel from the back, cause constipation, bloatedness, and depending on the position of them, they can also have some impact on fertility. Pregnancy can be quite painful, again, depending on the size of these fibroids and the positions. But in vast majority cases, fertility and pregnancy are not so affected by the presence of the fibroids. How do you go there? So why women referred? As I said, because of one of the symptoms, mostly it's heavy painful period, pressure symptoms. So when we examine, we discuss the symptoms. It's important to ascertain what aspect of the problem that we need to address. we need to do examination to ascertain how big are these fibroids. We can do abdominal examination. Big fibroids usually palpable through abdomen, and also we might need to do examination just to ascertain if we are to treat them surgically, which route we will choose depending on the size. I'll come back to that later. The main common investigations that we will do is ultrasound investigation. Usually this is done by primary care, and very often we see patients already with a scan present and guiding eyes where these fibroids are positioned. And in some cases, we will need to proceed with MRI. The MRI becomes particularly important if the question comes, if we're going to treat it with uterine artery embolization. MRI gives us answer if it's a one fibroid, if it's a large enough and it's got a distinct vessel that can be clotted as part of the treatment. Also helps us to ascertain if in case of a bigger fibroids, helps us to decide the surgical intervention depending on that as well. So treatment options, as I've mentioned in the beginning, fibroids are benign structures. The only time they can become cancerous in a very small percentage of cases, but in those cases, there is an element of sudden growth of those fibroids. And women do notice sudden increase in their abdominal girth and origin of a new onset of symptoms that they wouldn't have before, such as pain in particular. In those cases, we compare the fibroids and then approach to it in a more emergency situation. But in vast majority cases, those structures are benign. So we don't have to treat them unless until women are symptomatic of it. So it's very important for us to understand the symptoms that are we treating. As a primary symptom of it is a heavy and painful bleeding, we address heavy painful periods as we would in any other case, and that's usually done with hormonal treatments. Fibroids do respond well to progesterone-containing hormonal contraceptive treatments because it addresses both issues. It addresses the heavy periods as well as it to some degree restricts the growth rapid growth of the fibroids. Uterine artery embolization, as I mentioned, is when we clot that one vessel that feeds that large fibroid. However, this is only possible if we have one large fibroid which approaches the sizes. They can be around 10 centimeters or even more. So we would require MRI for that, and radiologist gives us an idea if will it work for this particular case or not. So this is decided on case-by-case basis. It's not a universal approach. If there are multiple fibroids, smaller fibroids, then this is not the best choice. Myomectomy is what is surgical removal of the fibroids only. We do this procedure when we need to preserve the uterus, or on a woman's preferences. So it depends. It can be done via keyhole procedure or it can be done as an open surgery. But recent recommendation is like try avoid any surgical intervention on the fibroids less than 5 centimeters, and larger than 5 centimeters are mostly being done by open surgery rather than laparoscopy. The success rate is very similar, but if there is a question of future fertility, usually open surgery has better results than laparoscopic surgery. So it just involves removal of the fibroids and keeping the womb. As I said, it is only recommended when there is a need to preserve the fertility function of the woman. And most definitive answer is hysterectomy. Again, it can be done via keyhole if the womb within the reasonable sizes, and if womb is too large with a bigger fibroid, then it has to be open surgery. I'll continue. Yeah. So next topic we will cover is HRT, hormone replacement therapy. It replaces obviously estrogen after the menopause. So HRT itself implies to primarily estrogen. But if woman has got a womb, then it has to be combined. So that also will include progesterone and may also include testosterone. Though testosterone in this country is not licensed for use as a HRT, it's widely prescribed these days. I'll come to that later on in a discussion. So the main symptoms of menopause, they are divided into subgroups. The vasomotor reaction of menopause is hot flushes, night sweats, mood disturbances, a higher level of anxiety, panic attacks, generalized joint and muscle aches. It can give cognitive reaction as well, reduced memory, brain fog, women describe. It affects the sleep deprivation, and caused by sleep deprivation, fatigue, even further reduction on a concentration. It can cause reduction in a sexual interest, reduction in a libido, and as part of the menopause is a vulvovaginal atrophy when menopause affects so-called down below, causes vaginal dryness, shrinking of the tissues, loss of architecture, causing difficulties in continuing sexual life. So, as I said, it's combination of the hormones. It can be estrogen only HRT if woman had a hysterectomy, or it has to be combined HRT, estrogen plus progesterone. HRT can come in all variety of forms. There are pills, there are patches, there are sprays, gels, rings. Depends again on the combination. They can be solo preparation or they can be combined preparation. Okay, I'll talk about. So in the past, HRT has been considered until 2019. HRT was considered quite a risky medication because of increased risk of a breast cancer. The recent HRT is considered to be more bioidentical. What that means, they are more closer mimics the human natural estrogen in particular. So it is considered that it's not increasing risk of a breast cancer. The increase in the risk of a breast cancer is not clinically significant. Let's not forget that the risk of breast cancer is always there. That's the second commonest female cancer, and it's quite wide in the community. How much this HRT causes the increase of the risk of the breast cancer, recent evidences have been quite reassuring. There are combined oral preparations that are still considered safe, such as Femastone. It comes as a combination of estrogen and progesterone, and we can also play around with the dosages of estrogen and progesterone in it. All these preparations will need to be adjusted and reviewed with the age, like at 55, at 60, as the round numbers. I think it is reasonable to have them reviewed. The bioidentical progesterone is utrogestan. It comes as a pill or it comes as a pessary that can be inserted vaginally and rectally. Vaginal use of utrogestan is not licensed for that particular use, but again, it's very widely prescribed these days, just to try to help women to achieve their desirable effect with a minimum impact on their own life and see which kind of progesterone they tolerate better, really. There are combined patches such as Evorel Conti, for example. It's got fixed doses of progesterone and estrogen in it. However, if women need more estrogen than it is in the combined patch, that can be added additionally as an additional patch or as an additional gel. One of the safest modalities of HRT can be especially in immediately after the menopause ages or in perimenopausal, leading towards the menopausal period when there are issues with the periods, can be myrinecoil, which is levonorgestrel, is considered one of the best progestogens available. It's considered a topical treatment. It works from inside the womb and has got very protective qualities on the lining of the womb. It's also been treated with this. We treat early stages or prevention of the endometrial cancer. Hence, it's one of the safest progestogens available for a backup of HRT, and it lasts 5 years. And it's very easy then to adjust the dose of estrogen if the myrinecoil is in situ. For a topical treatments, usually we use vaginal estrogen, and as gynecologists with interest in uro, we do recommend use of vaginal estrogen. I do recommend use of vaginal estrogen along with a systemic estrogen, because I think that topical area of the vaginal walls as well as bladder benefits a lot from just topical application of the estrogen, along with a systemic HRT. HRT is it's got very good beneficial effects on vasomotor symptoms, particularly the hot flashes, the night sweats. It helps with the generalized body aches. And most importantly, one of the main positive side effects, it helps to maintain both strength. Estrogen delays the breakdown of the bone cells, and is one of the most potent chemicals that prevents bones destruction. It has got beneficial effect on the delay and prevention of dementia. It's got potential effect of prevention of atherosclerosis and MI, so it's got generally very good impact on the heart. The only thing that needs to be aware of, that estrogen increases risk of clotting. So if there is any underlying condition that increases the risk of clotting in a woman, so adding estrogen to that has to be weighed up against the benefit against the risks. But it is possible. It's widely prescribed. It's just the titrating of those and finding the appropriate modality. When estrogen prescribed solo without adding on progesterone, there is evidence recently suggesting that it in fact delays and prevents developing breast cancer. So solo estrogen has got also beneficial effect on the developing of a breast cancer. Once HRT prescribed, it needs to be reviewed. Usually we allow 3 months to see the response to that, because very common we hear that women suddenly feel so much different. The effect is striking within first couple of weeks. But bear in mind, the effect is going to come down and plateau. So that's why we say 3 months, and then we review the situation. It is the absorption of the estrogen is not same in every woman. So sometimes we might need to do blood tests to ascertain the appropriate level of estrogen in the blood and change the modality if needs to.
Okay, thank you, Anna. So obviously we are gynecologists. We feel that women's body go through a lot of trauma when they go through menopause, and if not properly maintained, obviously it has its own side effects. So we do feel very strongly about management of the menopause as a gynecological body, I think. So the other thing which we get referred quite regularly is heavy menstrual period. So there is no definition of heavy menstrual period. It is what a person perceives, how heavy is their period, and how is they affecting your daily life. So it is purely based on patient's perception about how heavy is their heavy bleeding. And commonly what heaviness means, if you're passing large blood clots. So passing large blood clots, what that means is when you have any bleeding from anywhere in the body produces clots, because body tries to clot and stop the bleeding. If you're having too much of bleeding, then that means the same mechanism will click in your uterus, and then you will bleed with clots. So that means that you're passing large clots, means you're bleeding quite heavily because it's clotting more and more. If you're bleeding more than 7 days, and you have to keep changing big sanitary pads. So that kind of telltale sign what can be considered heavy periods. But there's no fixed definition of what is heavy periods. But if it's affecting you and you want to get checked, it's no harm getting checked. So as I said, the discussion is mainly the symptoms and your medical history. We do try to do examination to make sure there's no big uterus or not anything prolapsing through your neck of the womb like a polyp or a fibroid, which is causing you bleeding. We do test for anemia, and sometimes you might have disorders from thyroid functions, which can cause a heavy period. And then obviously, if we do an examination, we find it bulky, or we give simple medication and your symptoms do continue, we may have to go down the route of ultrasound. So what does ultrasound say? Ultrasound is mainly to rule out if you have any fibroids or any condition like a lining of the womb sometimes can have a polyp. Or you may have adenomyosis, which can cause heavy and painful period. And when we showed you the picture of fibroid, what Ms. Zakaryan was mentioning about a fibroid, which is submucosal, which is more of lining of the womb, or a large fibroid in the muscles of the womb, they can cause heavy period. Usually the subserosal fibroid, which are at the surface of the womb, they do not cause heavy periods. And even in the intramural fibroid, which is mainly the muscles of the womb, they call heavy periods if they are quite relatively big sizes. And the lining of the womb, which is a mucosal fibroid, even if it's 1 centimeter, can cause heavy period. So that is very important for differentiating. If a 1 centimeter fibroid is there on the surface of the womb, it's not going to cause any problem. But if the same fibroid is in the lining of the womb, it can cause a lot of problem. So our aim is obviously to give, if you're anemic, we want to treat it so that you get less tired. Then if there's no submucosal fibroid, the scan doesn't pick up anything major, then obviously we try to treat it with simple things like hormone pills, which can be any contraceptive pills, or a progesterone-only pill. Mirena coil or hormone-containing coil is very effective in treating heavy periods, and it works on 4 out of 5 patients, i.e. 80% patients. It does take 4 to 6 months for complete effect, and 80% of patients have no periods, or the period become much lighter. Then obviously, if there is fibroid in the lining of the womb or big intramural fibroid, that needs surgical intervention if it's symptomatic. And then if you don't want to do any hormones, but you can manage it with tranexamic acid, which is a tablet which helps to clot better and can reduce your chances of heavy bleeding, or and that may, if it works on its own, then you may not need even the hormonal tablet. So it's almost a common first line treatment. And to be honest, this has, when you go to your GP with heavy period, this should be the first line treatment, should have been started. So we should, when it comes to us, you should already have tried tranexamic acid and an ultrasound scan, or one of the hormonal pills if you're suitable for the treatment. If this have exhausted now, then we come for a surgical option. The surgical options are only options, especially endometrial ablation, which is basically burning the lining of the womb. It's a day case procedure. You have a look inside the womb with the camera. The cavity looks normal, or endometrium looks normal. Basically burn the lining of the womb and come out. It's a very small surgery. The recovery period is 3 to 5 days, i.e. we try to ask you to listen to the body. Effective in 80% of patients, i.e. 80% of patients will not have any periods, or periods become lighter. However, after your ablation, it's unlikely you're going to get pregnant, but it is not contraceptive. So it's only available for patients who have completed fertility. Myomectomy, which is taking the fibroid out if you have a large fibroid, that again, as I explained, is an operation where we take the fibroid out. We usually reserve this for patients who still wants to have more children. Otherwise, if you don't want to have children, and we need to do a surgical intervention, you got fibroid, we much prefer a hysterectomy, because obviously it's a definitive treatment. Second, myomectomy sometimes leave you with a lot of scarring. So it can develop pelvic pain, fibroid can reoccur, and if you have to have an operation again in future, then it leaves you with so much of scarring that any further surgery in the pelvis can be very tricky to do because of scar tissue. So if we need obviously, if you want to conserve fertility, then we don't have an option but to offer you myomectomy. But if you're not conserving the fertility, if you've got fibroid, or even if you don't have fibroids and heavy periods which have not responded to the normal treatment which I've just described, then we may have to do a hysterectomy, and that's a much more cleaner surgery than a myomectomy, even for future and definitive. Obviously, it's a major surgery. Majority of hysterectomies we do for heavy periods are either keyhole, which is got a big early recovery periods. Only, or sometimes we can do it vaginally as well. Only hysterectomies we do open are patients who have got large fibroids or they're not mobile. So we don't have spaces to put the camera in and do the operation safely. But majority are doing keyhole, or occasionally we can do it from vagina. Other thing which we get referred is an ovarian cyst, and majority of ovarian cysts which we see or get referred are benign small cyst which doesn't need any treatment. So these are the physiological cysts. So every woman who's in reproductive age group, if we scan, at least 1 in 4 women will have some kind of cyst in ovaries, because that's where you're producing the egg from. And that doesn't need treatment because it will resolve on its own. However, there are other cysts which will not resolve and can cause issues with you, which can, sometimes they're just silent because you can't see them. And then once you get problem, then they are picked up. But they usually can pick up as pelvic pain. Big ovarian cyst can produce bloating. You can have pain during intercourse. And sometimes because of cyst, if you imagine ovaries, I've shown the picture of ovary before. It's a very small organ, this big, 1/4 of size of your finger. The blood supply is with a small stalk. So if it's a balloon-filled cyst forms up with the size of that string which are attached to a balloon, which is the blood supply, sometimes it gets twisted in the body, which can cause stopping the blood supply to the cyst, and that can cause emergency pain, which is called ovarian torsion. And very often you might not have any symptoms and you get scanned done for some different reason and the cyst is formed. So quickly, medical history, pelvic examination, ultrasound, we'll know what's happening. Now, depends on what kind of cyst you have, then the treatment is. If you've got a small cyst, which is benign looking, which majority of them are, we usually try not to do anything. It's a watchful waiting. If the cyst is example, the endometrioma, which is a endometriosis in the cyst, and it's causing you symptoms, when you do a keyhole surgery and try to take the cyst out. If the cyst is more than 5 to 6 centimeters in size, and it's even a simple cyst which is benign, we try to discuss with you about various options, including taking the cyst out or observing. Some cyst, for example, what is called a dermoid cyst, which starts from ovarian cells, and it can have anything inside, which can you can have teeth, because ovaries can produce a whole baby. So this cyst can produce anything inside. Usually have sweat and hairs, but sometimes you can have teeth, bone, everything else. If it's more than 3-4 centimeter, 5 centimeter, there's an option of taking this out and do it laparoscopically. Some cysts are suspicious. If they're growing up in your size quickly, or they're not clear diagnosis of a dermoid, endometriosis, or a simple cyst, then they may have abnormal features on an ultrasound scan, and then we may have to do the blood test to ensure that these are not suspicious cyst or cancerous looking cyst. And also at that point, we may like to do a further investigation or imaging of investigation like an MRI. We do all the benign ovarian operations here. Obviously, if a suspicion of cancer takes place, then this will have to go to the cancer hospital, it's a NHS hospital for cancer treatment. But if there is cyst is growing up in size or the scan has got suspicion, then we do all the tumor markers and get an MRI done here to rule out any suspicious changing on the cyst. So that's about the ovarian cyst. But lots of time you get a small cyst referred, which really doesn't need any treatment. And the last thing which we want to discuss briefly today is what is called polycystic ovaries. There are a lot of myths around polycystic ovaries, and polycystic ovaries, first and foremost, I would like to say it loud, it's not a disease. Up to 1 in 4 women are born with polycystic ovaries. So if your ovary, as I said, is about 1/4 of your long finger size, and if polycystic ovaries may be marginally half to 1 centimeter bigger than that, that's about it. What happens if you look at the right side, where you can see the polycystic ovaries, every cycle you're producing an egg, and your ovary is producing an egg. But for patients or women, rather than patients, the women who have polycystic ovaries, those eggs are not getting released. And therefore, they found a lot of small follicles. And that's how when you do a scan, it looks like multifollicle ovary, and hence the term polycystic ovaries. Now, polycystic ovaries, the myth is, if you go for a scan and they say polycystic ovaries, we assume that that is the cause of your pain. Polycystic ovaries don't cause pain. They're just a small variation. And the spectrum of polycystic ovaries can start from having no symptoms, and you go for a scan and you pick up polycystic ovaries, to a spectrum where you have no periods whatsoever. And you get a scan, which is polycystic ovaries are confirmed because you're not ovulating. Polycystic ovarian syndrome is slightly different than polycystic ovaries. Polycystic ovary is just a marker on a scan. Polycystic ovarian syndrome is 2 out of 3 features. One is scan finding. Second, on blood test, your testosterone level or sex hormone binding globulin, which is slightly, the male markers of the hormones are slightly high, or you got menstrual irregularity. So 2 out of 3 then constitute polycystic ovaries. Now, polycystic ovaries don't need treatment. It depends on how it is affecting you. If you got irregular periods and you have up to 3 periods a year, that means you're menstruating. And if you're not planning for a pregnancy, then this does not need any treatment, because 3 periods a year are enough to protect your lining of the womb. If you're having no periods, then we have to give you something like a progesterone supplement to shed the lining of the womb 3 times a year, or Mirena coil to make sure the lining of the womb doesn't get abnormal. If you're not able to conceive because of polycystic ovaries, because you're not ovulating, then certainly it needs treatment, and you need further workup done and treated to make your ovaries ovulate. Then some spectrum of irregular bleeding happens when you have irregular spotting, bleeding, which you don't know what's going on. We can't treat the polycystic ovary, but we can treat your symptoms. And the symptoms are, so treatments are, again, going back to hormone contraceptive pills, Mirena coil, and depends on what is affecting you. This, as I said, polycystic ovarian syndrome have got slightly high testosterone level, which can give you excessive facial hair and oily skin and acne. And those are treated by, if you have excessive weight, we need to reduce the weight, because that will help to kickstart your ovaries, reduce insulin resistance, because they have got high insulin resistance, and that will kickstart your ovaries and help. However, with excess facial hair, some medication like Gynaecology, which do reduce a bit of excessive facial hair and growth. But if it does continue, you may like to see a cosmetic doctor or a dermatologist and see whether they can help you with anything. Some polycystic ovary patients have got excessive weight, and until that weight is shed, nothing will work. And they do find difficulty in losing weight, so this has to be recognized. And hence, if they do find difficulty in losing weight, then a specialist input in those kind and weight loss may be helpful. And I just said about the diagnosis, what is required, 3 out for a syndrome. And treatment is really based on what is your symptom and what's affecting you. There is a patient information leaflet which you can find on Royal College of Obstetrician and Gynaecology website. And if you just go to the Royal College of Obstetricians and Gynecology website and search for polycystic ovaries, you'll have a polycystic ovaries leaflet, and that's all you need to read to know about this condition. Obviously, the long-term condition, because of weight and you got high risk of diabetes and cardiovascular disease. But as long as you can maintain a healthy lifestyle, this polycystic ovaries then don't need any treatment. I think that's it, Vicky.
Lovely. Thank you both for your it's really interesting presentation there. So just going to move on to the Q&A session. We've got sort of 10 minutes or so for your questions. Really delighted to have so many of you with us today. We might not be able to answer every question, but we'll do our best. We've got quite a lot of urogynecology questions here, so we will get back to you about these, but we will going to focus on the gynecology. I think the first one we can have here is postmenopausal from Christine. Hi, Christine. Postmenopausal patients needing effective vaginal relief from vaginas can be given vaginal gels. What are the risks of using these?
I guess that depends what vaginal gels we're talking about. Gel, even vaginal estrogen can be given as a gel. The best thing that helps vaginal dryness is vaginal estrogen in conjunction with natural oils that was found to be more effective recently than just water-based gels, such as cooking coconut oil. There is a Victory oil with a combination of oils in it for intimate use. This can be used externally as well as internally, and this can be used in conjunction with vaginal estrogen. The other gels there are preparations called Yes or Silk. They are simply water-based pH neutralizers. They do not have repair and long-term impact. They just make things comfortable and maybe help as a lubrication for a sex. But neither of those carries any risk as such. Even vaginal estrogen these days considered to be relatively safe for breast cancer survivors if they done in appropriate minimal dose, so it can be used for a longer term.
As Ms. Zakaryan said, vaginal estrogen are quite safe. And obviously, if you have breast cancer a long time ago, again, a short duration of vaginal estrogen will not do any harm. But if you have an ongoing issue, breast issues, then you can always discuss with your breast surgeon and the oncologist, and then we can recommend vaginal estrogen. But vaginal estrogens are very little which comes in your bloodstream, so it's mainly local, and it does give a lot of different benefit, including obviously discomfort affecting your waterworks and various kind of irritation. So yeah, it's quite safe.
I think I'll answer Yvonne's question as well. Can menopause cause severe skin irritation where any contact, even clothing, is painful and itchy? You'll be surprised the amount of the population suffering from this. Yvonne, please don't feel isolated. I start from saying this. This is a very common problem, unfortunately, not as much spoken about. It is not uncommon what you're describing. Again, back to what I've just said, the main preventative treatment is with vaginal estrogen, a lot of moisturizing, and that comes, I can't say it enough, hydration of the tissues with the oils, natural oils, any soft oils, feel free to use them. They have to be used externally and internally along the whole labial area, perineal area, perianal area, as wide as you feel need for that. Hydration is primary. If the symptoms are so unbearable, you can be prescribed steroids, topical steroids, Dermovate, Humavate. GPs very commonly prescribe hydrocortisone, but bear in mind, steroids are there only for a symptomatic relief for a short period of time. They can be used aggressively just to provide you some relief. They are not for a long term. Use only them during the flare-ups. If the symptoms this bad, you may need to use some Piriton or antihistamines overnight to prevent yourself scratching from yourself. because that will add on additional inflammation and worsening of the symptoms. If the symptoms are so bad, I will recommend to go for vulval biopsy just to have some histological confirmation of the diagnosis. Always good to have it on a background to know what is the change in the tissues.
Okay, lovely. Thank you, Anna. I hope that was helpful, Yvonne. Next question is from Judith, and Judith says, for someone who has had open surgery done before for fibroid removal and wants to have children, but the fibroid regrows, what advice can you give them?
Yeah, so if you have, as I said, we can't stop fibroid growing. If you had a previous open surgery for removal of fibroid, so I assume that you are saying that you had a myomectomy done already. If you want to have more children, obviously you can try and you get pregnant, and if you have a fibroid which is regrown, does not need any further treatment. However, if you have the fibroid, and it depends on where these fibroids are. If the fibroids are quite big again, and they are pressing on the lining of the womb or distorting the cavity, and giving you a lot of symptom, pressure, pain, heavy periods, difficulty in getting pregnant, or sometimes a recurrent miscarriage if you're distorting the cavity. So it really depends on where this fibroid is. If the fibroid is just in the lining of the womb, then it's easier because then you can do a hysteroscopy resection, i.e. we can go through the vagina, through the neck of the womb with a camera and resect that fibroid. But if it's again in the muscles of the womb and it's affecting you, and in one or the other, which I've just described, then very occasionally we may have to remove the fibroid again. But if you have to remove the fibroid again and you have desirous to having a fertility, then it's always wise to plan your fertility then. So once the fibroids are removed, once you heal up from the fibroid operation in 3 to 6 months' time, you should start trying for a pregnancy. Then again, we don't want to remove the fibroid, and then if you're not planning for pregnancy in next 2 or 3 years or 5 years, then we may be again in the same situation. You might rather manage your symptoms and only have the operation done when you're just there when you want to start trying for pregnancy. Obviously, we need time to heal up after the operation, but until unless the fibroids are deviating the cavity or you got large symptoms, as I said, you don't have to have it removed. But if you're getting really symptomatic, then there's other ways to manage your symptoms till you are there to complete your fertility. And then we do the operation, and then you can try for pregnancy. But doing a removal of fibroid, again, a myomectomy, is incredibly a tricky operation.
Okay, thank you, Mr. Gupta. So we've got time for one more question, and it's just around vulval pain. I wonder if you could say something about that, what the treatments are.
Pretty much the same. It's part of the vulvovaginal atrophy. If everything said above doesn't help, then we have to consider prescribing neuropathic relief medications such as amitriptyline or gabapentin. Usually we tell that in advance to the patient and the GP. It's very commonly prescribed, nothing unusual, anything to provide relief. But estrogen is the main preventer factor, moisturizer is the main support.
Okay, lovely. Thank you both.
Can I just say about the vulval pain one more? Some of the patients may get pain, may not be vulval pain, but can get pain from during intercourse or feel vaginal pain. And that can happen with something called a hyperdynamic pelvic floors. So they may not find any pathology, but they get a lot of pain because they're keeping the muscles very tight. And that's what happens when you get a spasm on your back or anywhere else, because if your body feels that you're going to have an unaccustomed movement or unaccustomed impact, and then you tense your muscles. And when you tense the muscles, it forms knots, and that can cause a lot of pain. So it's a complex feature. And then usually our specialist pelvic floor physios do help in that situation. But apart from that, the outside one, which is vulval pain, is just what Ms. Zakaryan has just described.
Well, pelvic physio helps in any case. Physio, massage, any supportive treatment and physio is part of it, do usually have a very beneficial impact.
Lovely, thank you both very much. Thanks to everyone for your questions and being part of this evening's sessions. If we haven't covered your question, and I'm very aware that we've had a lot of urinary-based questions that we haven't answered, and we will follow up with you via email after the session. So as a thank you for attending, we're very pleased to offer 50% off the value of your initial consultation, a call back from your dedicated private patient advisor, an email with a recording of this session, treatment information and loyalty scheme reward points, and updates on our future events and health news as well. We'd really appreciate it if you could take a moment to complete the short survey that you'll receive at the end of the session, because it helps us to improve and tailor future webinars to your needs. If you'd like to speak to someone to book your consultation, our private patient team is available until 8 p.m. this evening, and then from 8 a.m. to 6 p.m. Monday to Friday, and you'll find their contact number on the screen just there. We've got some more webinars upcoming on a range of topics, including men's health and cataract surgery, and you can sign up for these on our website. So finally, on behalf of Mr. Gupta and Ms. Zakaryan and everyone here at Benenden Hospital, thank you very much for joining us, and we hope to hear from you soon. Thank you.
Thank you.
Have a good evening.